Greetings all, this is Rhett Ketterling. At this point, I'm assuming I should be thanking Yasmin Akari for such a nice introduction, although in the in the current system I didn't get to hear it. But knowing Yasmin, that's likely true. I wanted to start this talk by focusing on the topic of privilege, which is something that's on all of our minds in the current environment. And to begin with, it is definitely a privilege to speak with all of you today, and I want to thank my friend and colleague Yasmin for the invitation, and of course all of those at CGC for allowing me to speak today. It's also a privilege to work in the field of genomics. It's a great field for all of us, and particularly for me, working in the Mayo Clinic Genomics Laboratory, where I have these wonderful group of people. There are 15 of us boarded in cytogenetics, most of us boarded in at least one other specialty as well. And it is a true privilege to work with this amazing brain trust here, and I rely on their input every day. I had the great privilege as well of training at Mayo Clinic. As seen off to the left here in the upper right are the laboratory buildings where I ended up, but I began on the lower right, which is an image of Mayo Medical School, which is embedded downtown, and I had the great opportunity here to train for those 4 years and ultimately achieve my medical doctorate. When I finished my degree, my great research mentor and clinical colleague mentor, Dr. Steve Summer, said, "Others may call you medical doctor, but I will call you mutation detective," which I thought was just the perfect explanation to me of what this degree actually meant, certainly for my future. And for you PhD colleagues, I think phenotype detective might be another term that we can use, but the bottom line is we are all detectives in what we do. This was particularly important to me because as a kid, I absolutely wanted to be a detective. I even had my own detective kit, and I developed that after reading all of the Hardy Boys books several times. So Frank and Joe were my initial heroes. And it was just a matter of time before I became a Hardy Boy, Frank, Joe, and Rhett, shown here solving the Tower treasure. But being a detective was clearly in my genes, so to speak, and I really was very excited about being a detective in my career. I had the great privilege as well of doing my pathology training here at Mayo. And as you can see, I developed significant skills during those 4 years. That's me up here on the top. I try to wear more clothes than that typically to work. But I am a pathologist, and that's really what I wanted to talk with you all about today, was how a pathologist thinks about the tissue that we evaluate and ultimately the fish or FISHues that we encounter on these tissue specimens, because it is sort of a unique application, and we have different challenges in evaluating paraffin tissues. So a reminder of the tissue types that actually come in for evaluation. We have excisional biopsies in the upper right here, showing a larger piece of tissue that can be removed, like a full lymph node or a portion or hopefully all of the tumor sample. More frequently, it seems, in the lower right, we get these needle core biopsy specimens that are just a smaller representation of the tissue. And in addition, you can have cytology, as illustrated in the lower left, showing the blood and small fragments of tissue that are aspirated out of the tissues of interest. A reminder then that the excisional biopsy is clearly the best representation of the tissue and your best representation of disease. The core biopsy is a focal representation of the tissue and may or may not be a good sample for us to evaluate, and cytology specimens are definitely challenging where you have focal and dissociated cells that are hopefully representative of the mass or tissue of interest. So with that in mind, I'm going to be presenting a series of cases to you today that illustrate some different teaching points I thought were useful for you all to hear on tissue evaluation. The first is a 65-year-old female who presented with a breast mass. Needle core biopsies were obtained, and ultimately a diagnosis of invasive ductal adenocarcinoma was made, and it was sent to our laboratory for her FISH studies. Here's an example of a needle core biopsy demonstrating invasive ductal cancer. Typically, a pathologist will see this H&E and circle it appropriately and mark the area of invasion, or sometimes the entire sample, for us to evaluate. There were two results generated on the FISH sample from this patient. The first was a normal result, as illustrated in the image, showing a normal ratio of 1.18 of the HER2 to 17 centromere, and only on average 2.3 HER2 signals per nucleus. The second result was an amplification that was observed in about 10% of the nuclei, showing a ratio of 2.35 and an average HER2 per nucleus of over 6, in this situation almost 8 copies. So with these two results generated and imaged by the technologists, what is the significance here? Is this a heterogeneous population, just a partial amplification? Or, since the significant percent of the cells that were scored were actually essentially normal, is it possible these are not even tumor cells or non-neoplastic cells, and thus this really just represents an amplified sample, but not a heterogeneous specimen? I thought it would be useful to show a few images of an H&E versus the DAPI staining that is observed in the FISH area for comparison, so that you can appreciate the difference between the two. As I like to tell people, the pathologists get the easy job. We get the nice color images, and we also get to evaluate things on low power. And as I was taught in training, a low power pathologist is a high power pathologist, meaning that when you look at things on low power, you get the more global view, and that's often where you make your diagnosis, or you understand what's actually happening in the tissue specimen. In the left image here is an H&E showing the central two large glands that are solid and non-invading, or the intraductal component, and surrounding it are all of the small infiltrative adenocarcinoma glands, which are what we want to evaluate. Looking at the DAPI image, you can easily see the large solid glands, but appreciating the small invasive tumor on the periphery is much more difficult. This is the typical example of breast cancer, meaning that smaller infiltrative glands are the invading tumor of interest, and the large solid or large ringed structures of in situ or intraductal is what we're supposed to be avoiding in our FISH evaluations. I've included this second slide demonstrating the H&E image versus the DAPI image to show why this is so difficult in certain cases. So on the left, there are some smaller glands that are visualized in the upper left portion of the H&E diagram, but those are actually in situ in this situation. They're lobules demonstrating what's called cancerization of the lobules, or non-invasive tumor in that scenario. The two large glandular looking structures in the center are actually tumor that's invading through vascular invasion or lymphovascular invasion. And so in this particular example, it's the large gland appearing structures that should be scored for FISH. So we document this type of thing in our H&E reviews, and about 5% of our cases that we review for Paraffin FISH are indicated as a scan and see pathologist for the FISH technologist who's evaluating it. So that way we can verify that they're ultimately looking at the tissue that we think they should be scoring in these particular cases. For this particular case, when we went back and looked at the HER2 cells that were normal, they were indeed tumor nuclei. So this needle core was demonstrating a heterogeneous result. So in this situation, since only a needle core or a portion of this tumor was evaluated, we comment on that and say a subpopulation of cells had HER2 amplification, and a repeat FISH testing for HER2 on an excisional or larger tissue biopsy specimen could be considered and is likely recommended to resolve what true population of cells in this patient's tumor do demonstrate HER2 amplification. The second case is of a 70-year-old gentleman who had inguinal adenopathy, and the needle core from one of these lymph nodes demonstrated a diagnosis of diffuse large B-cell lymphoma, and that a portion of that specimen was then sent to our laboratory for quote-unquote double hit lymphoma evaluation, or high-grade B-cell lymphoma with MYC and BCL2 and our BCL6 rearrangements. So we did FISH for BCL2, BCL6, and MYC. The BCL2 result, as demonstrated here, is showing a disruption, and that was seen in about 95% of nuclei. The BCL6 result was normal, intact fusion signals. The MYC result was the challenge. So this is a lower power image showing the occasional FISH nucleus that clearly shows a disruption, but the majority of these were normal per the FISH evaluation. So they indicated it was overall about 5% of the nuclei had a MYC rearrangement. So what does this mean? Does this represent a high-grade B-cell lymphoma with MYC and BCL2 rearrangements, or a double hit? This is a pretty important genetic evaluation that ultimately leads to this diagnosis and different therapy. Honestly, we think this is unclear based on the sample that was evaluated. So in these situations, we interpret the BCL2 as abnormal, and the MYC result we report out as equivocal. Again, since this was a needle core biopsy specimen, we have a similar comment to what I mentioned in the HER2 evaluation. Since we only looked at a needle core and approximately 5% showed this MYC rearrangement, we suggest a repeat FISH study on an excisional or larger tissue biopsy specimen. This is not an uncommon finding in our lymphoma practice, and we see this perhaps not every week, but not infrequently. So we have received multiple follow-up specimens on these cases. Some continue to demonstrate this low-level MYC rearrangement. Some of them are resolved, and you don't see the MYC rearrangement of any significance in the bigger tissue. We've had at least 3 or 4 cases where a lymph node was ultimately excised, and the majority of the cells showed a MYC rearrangement, or leading to this diagnosis of high-grade B-cell lymphoma with MYC or BCL2 or BCL6 rearrangements. Follow-up testing with larger tissue specimens can definitely be important based on the tissue that you're evaluating. The third case is a 55-year-old male with bone pain and pancytopenia, and a bone marrow biopsy was obtained, which led to a diagnosis of plasma cell myeloma. Unfortunately, in this particular case, the bone marrow aspirate was unsuccessful, as definitely happens on occasion, and in this situation, this results in a lack of our ability to perform the typical targeted interface plasma cell FISH. So we received a call from this pathologist saying, is there any way that you can please perform FISH on the paraffin embedded bone core biopsy? Most laboratories do not proceed with bone FISH evaluation. Here's an example of what this bone core would look like, and you can see that there's bone spicules in this needle biopsy, as well as this large infiltrate, which on higher power is showing the plasma cells of interest here. So I thought it was worthwhile quickly reminding people about fixation. Most tissues that are fixed in formalin, which is what we typically evaluate then in the genomics laboratory and has good results from a FISH perspective. There are definitely non-formalin fixatives, some mercury containing like B5 or Zenkers, or other chemical compounds. Glyoxal is what's used in the prefer fixative. These often result in FISH failures and damage the DNA during the process of fixation. Bone is a special case, you can't cut through bone unless you remove the calcium that's there. And so decalcification has to occur on all bone specimens before histology can be performed. The typical and historic way to do that is to immerse the bone in acid. Formic acid is typical. Unfortunately, that results in failure of any genomic evaluation. The DNA is degraded with this heavy acid exposure, and you can't do anything, although the tissue is still fine for morphologic evaluation. There are other decalcification solutions that can be used, one being EDTA, which chelates the calcium out of the bone, or even a limited formic acid exposure of a lower concentration, or light decal as some call it. Both of those can result in successful fish evaluation and DNA extraction for those of you that do other molecular testing. Fish evaluation on this particular bone core was successful, and the plasma cell fish studies demonstrated cyclin IgH fusion and monosomy 13 are a favorable clone in this patient's myeloma. In our experience, about 50% of the cases submitted for fish testing on bone or decalcified specimens are successful. Most of these have EDTA or this light decal process performed, but occasionally we get the ones with heavier decal to be successful by fish as well. So just a reminder that this process of decalcification in bone does not preclude fish evaluation or the extraction of DNA from these specimens for evaluation. The next case is a 35-year-old female with gastritis and a 10-pound weight loss. She underwent endoscopy, and the gastric biopsies that were obtained demonstrated a lymphoma diagnosis. They strongly favored mantle cell lymphoma, but MALT was still within their differential. They ordered fish studies in our lab on this biopsy specimen for cyclin IgH. The CCND1 IgH fish was normal and was released, and at that point we got a call from the pathologist saying, are you sure? There's really strong cyclin D1 staining, and we are pretty confident in this mantle cell lymphoma diagnosis. So could you please figure out why you're seeing normal? A review of the biopsy showed this, which I think is a good explanation and a learning lesson for us all. The lymphoma tissue, as seen here, the dark blue is crushed or almost unanalyzable in this gastric biopsy. There are cells that can be evaluated, shown here and here. And those are the cells that then the text will focus on and score. The cells that are scoreable correspond to gastric glands and vascular structures. And so these are benign cells, thus leading to a normal cyclin D1 IgH result on this specimen. So the tumor in this situation is essentially unevaluable, but the text, because they can find cells of interest or cells that they can find with fish signals, scored normal here, so this was a false negative. A pathologist evaluating an H&E slide is supposed to circle or mark the area of interest that should be ultimately evaluated and transferred onto the fish slides. In this situation, typically this is the tumor versus non-tumor, or this is the area of fetal tissue versus maternal tissue in a product of conception. But aside from identifying the areas of interest on a slide, there are definitely other things that should be noted by the pathologist when encountered. As indicated in the example we just discussed, crush artifact or significant tissue artifact due to the process of how the tissue was acquired, or the fragility of it, or maybe cautery, where it actually burns the tissue, all of that should be commented on with the concern that this may not be evaluable by fish. Additional things that should be commented on are the presence of necrosis. In this situation where the vascular supply is cut off from the tissue and the cells die or are in the process of dying, but they retain their cell shape, which is the definition of coagulative necrosis. So you can see the cells sort of as like ghosts on the H&E, and they will look like cells that should be evaluable or should be able to be evaluated on the fish slide. The presence of minimal tumor versus what's present on the slide, in other words, extensive non-neoplastic cells or small amount of tumor cells, should also be commented on. This can be because of the cellularity of the tissue, significant inflammation, the body's doing its job responding to the tumor, or if there's just very minimal tumor in the biopsy that was obtained. This is an example of the coagulative necrosis I mentioned, where you have some cells here with the blue nucleus still present, but the majority of them have this pink outline or this necrotic appearance, so the DNA is missing. And again, FISH testing on this particular type of specimen might yield some results in these few nuclei that are still apparently intact, but often those are just the inflammatory cells that have come in to clean up the necrotic tissue that's occurring. An example of a very cellular tissue. This was submitted as a spleen specimen involved by diffuse large B-cell lymphoma, and identifying the tumor cells in here is essentially impossible. There's lots of non-neoplastic cells present here, and so the idea that we could do a fair FISH evaluation in this situation is unlikely. Similarly, getting a good FISH evaluation when you have a very focal or small area of interest. This was a larger lymph node that essentially was all normal lymphocytes except for this small focus of large cell lymphoma or transformation here. So focusing in on this little area without knowledge that that's what you should be doing, again, is going to be a problem for FISH. The next case, number 5, is a 60-year-old gentleman who had abdominal bloating, and ultimately a CT was performed which demonstrated an enlarged liver and an enlarged spleen or hepatosplenomegaly. A liver biopsy was obtained, and path review showed this atypical T cell infiltrate, and the concern was, could this represent hepatosplenic T cell lymphoma? This is one of those rare T cell lymphomas. Seems like most T cell lymphomas are rare. This one has characteristic abnormalities of chromosome 7, i.e. an ISO7Q, and abnormalities of chromosome 8. Gains of 8Q or trisomy, tetrasomy 8 are common in this particular diagnosis. So we offer this FISH testing, and that was what was ordered on this patient. This shows the liver biopsy from this patient. There's these liver cells in the background, but there's this diffuse infiltrate here of these small lymphocytes corresponding to this T cell process. And there's tropism or an involvement, particularly here in these vessels or vascular spaces for this T cell infiltrate. FISH testing demonstrated gains of chromosome 8, trisomy, tetrasomy, as illustrated in this image. And the same thing was observed for the chromosome 7 probes. So gains of chromosome 8 would support a diagnosis of hepatosplenic T cell lymphoma. The actual trisomy, tetrasomy of chromosome 7 would be a little unusual, but the text said actually there were some cells that really looked like it could be a possible ISO7Q. So do these abnormal FISH results support the diagnosis of hepatosplenic T cell lymphoma in this case? Before I answer that, patient case 6, another evaluation of liver in a 75-year-old female with a history of breast cancer who now presents with fatigue and elevated liver enzymes. And the CT in this situation unfortunately showed multiple hepatic or liver nodules. The liver biopsy in this patient showed metastatic breast cancer, which then was submitted for HER2 FISH studies. This is an example of what this biopsy would look like with metastatic carcinoma on the lower portion, those glandular structures, and then the liver, the normal liver, above on the top. The circled area, or the area of tumor in this situation, demonstrated a normal HER2 to centromere 17 result. The area that wasn't circled, or that corresponded to the normal liver apparently, demonstrated this abnormal result of 3 to 4 copies of the HER2 and centromere 17 probes. So again, within the circled area, a normal ratio, a normal HER2 signal pattern. In the uncircled area, a bit elevated ratio, but the average HER2 was over 4, an equivocal result. So one possibility is it that the paraffin cut on the fish slide somehow got inverted, which definitely happens. Matching them up is not always as simple as one would believe. So what is the answer for cases 5 and 6 here? It's that the normal liver contains tetraploid nuclei. The liver is regenerative and reactive to processes in it like the increased lymphocytes or the metastatic tumor, and it's frequently identified with tetraploid hepatocytes or tetraploid liver cells. So the answer for case number 5, where we saw cells with additional copies of chromosome 7 and 8, that was the liver cells, and the small lymphocytes actually demonstrated a normal FISH result, so there was no abnormality in the T cell population. Similarly, in case 6, the tumor nuclei really were HER2 normal, and it was the hepatocytes that showed this gain of HER2 copies, or this potential equivocal result. So the take home here is that for enumeration probes, it's easy to generate a false positive result when you're evaluating liver specimens. So in addition to liver, there are other tissue types that demonstrate tetraploidy in a normal situation. We obviously know about bone marrow and megakaryocytes, which are typically tetraploid, but there's also reactive bone marrows, whether they're regenerative or proliferative due to growth factors like erythropoietin. It's not uncommon to see erythroid precursors present in a tetraploid fashion, and we've seen this multiple times, particularly in the pediatric population. Cardiac myocytes also have the potential to be tetraploid, although we typically don't get in cardiac biopsies for evaluation. In products of conception, the trophoblastic or the placental tissue often has a propensity to be tetraploid. So if you have trophoblastic proliferation, you can see many tetraploid cells in this situation. In reading, it appears that tetraploidy is increased in essentially all tissues as patients age, and presumably this is due to a loss of control of the mitotic apparatus, but tetraploidy at least some level in tissues, particularly in elderly patients, should be something to be considered. The conclusions that I want you to take from this talk are: consult or interact with your pathologist when you're doing these evaluations if you have any questions at all. The type of biopsy can impact the interpretation of the FISH result. Again, smaller biopsies, needle cores, aspirates, and so on is not a particularly thorough evaluation. So if you have unusual results, getting more tissue is recommended. The difference between a paraffin H&E evaluation and the DAPI evaluation by the technologists is difficult. They have a much more difficult job. And trying to understand what it is that they're seeing versus what's on the H&E is critical. Fixation is clearly important, but does not necessarily preclude analysis in decalcification, and those specimens should be considered for evaluation or validation in your laboratories. A pathologist review should be thorough and not just include marking the tumor or marking the fetal tissue, but commenting on other additional factors like artifact, necrosis, small tumor populations, and so on. Overall, I think it is a privilege for all of us to participate in patient care. We make a difference every day that we're on our jobs, and I hope you thoroughly enjoy being a detective in this great world of genomics. I would like to acknowledge my terrific Mayo Genomics colleagues, all of the employees of the FISH laboratory, which currently number about 100. We have a very brisk practice here and see about 700 to 800 cases a week, which is why I could draw on so many of these examples that hopefully were educational to you. I also want to thank my amazing administrative assistant for her help, particularly in recording this presentation, Cherish, and Reed Meyer for his help with the slides. In closing, I just wanted to say thank you again, and I'd be happy to take any questions.